Thank you all for joining us today for another Moving to Value Unscripted podcast. My name is Dr. John Rodas, and I am a recovering ex-hospital president and am proud to be president of the Moving to Value Alliance. The MTVA is a 501c3 nonprofit grassroots community that aims to create a value-based healthcare ecosystem with high-quality outcomes at a reasonable cost for plan sponsors and their members, beneficiaries, or employees. I want to thank our members whose support make this podcast possible. We'd like to give special recognition today to our trade member, Capital RX. I'm joined today by my fellow board members, Lisa Trumbull and Dr. Steve Schutzer. Lisa is the CEO of Sohn Health, Southern New England Healthcare Organization, a physician-led, clinically integrated delivery system in Connecticut and Massachusetts. Steve, a nationally renowned arthroplasty surgeon, is one of the founders of MTVA and is co-founder of Upswing Health. Our special guest today is Dr. Kevin Bozic, Chair of Surgery and Perioperative Care at Dell Medical School at the University of Texas at Austin. Dr. Bozic is an internationally recognized leader in orthopedic surgery and a driving force behind the movement towards value-based healthcare. He brings a unique mix of clinical expertise, research insight, and policy experience, with a focus on building care models that truly improve health, not just reduce costs. Dr. Bozic's clinical practice focuses on managing hip and knee problems, including reconstructive arthroplasty surgery. He also holds an MBA from Harvard Business School and remains involved with Michael Porter's Institute for Strategy and Competitiveness. Since joining Dell Medical in 2015 as the founding chair, Dr. Bozic has built a department that emphasizes delivering real health, not just services. He credits this philosophy with not only improving patient outcomes, but also mitigating provider burnout and turnover. We're excited to have Dr. Bozic here with us today to discuss why we need to focus on the true value over cost containment. Welcome to Moving to Value Unscripted, Dr. Bozic.
Thank you for having me. I'm excited to be here.
Kevin, you've had a great career and you're still having a great career. Let me start, if I can, just why don't you tell our listeners about kind of your journey? And in particular, I'm kind of thinking you may be one of those guys, kind of like me, that started out wanting to be a good doc, good clinician. You know, you want to be a good orthopedic surgeon. I wanted to be a good obstetrician. And along the way, we published some papers, did some clinical research, and worked our way up the academic ladder to full professors, and found ourselves all of a sudden as department chairs, not necessarily jobs we sought. Other people, on the other hand, kind of start out thinking, I'd like to be a department chair someday and build a department. And I'm wondering which camp, I guess, you fall into. So could you just share with us your journey and in particular, how you kind of started thinking about value in healthcare?
Yeah, thanks. So I was one of those people that decided I wanted to be an orthopedic surgeon before I decided I wanted to be a doctor. So when I was 13 years old, through an experience with an orthopedic surgeon, which I think is pretty common for orthopedic surgeons and maybe doctors in general, went to college at Duke to do biomedical engineering with the intention of becoming an orthopedic surgeon, and went to UCSF for medical school and did my residency in the Harvard Combined Orthopedic Program. And while I was there, I came across a mentor, Jim Herndon, who was a leader in orthopedic surgery, a past president of the American Academy of Orthopedic Surgeons and the American Orthopedic Association. And he had a business degree, and it really intrigued me. And during my fourth year of residency, where everyone is supposed to apply for fellowships, I thought to myself, boy, I know a whole lot about clinical orthopedics and not much about anything else. And I hear all these people complaining about the direction the health system's going and the loss of autonomy for physicians, et cetera. And I thought, well, if I, go to business school, I can learn a new skill set and maybe bring that back and apply it to my day job. And lo and behold, I ended up finishing residency and spending 2 years at Harvard Business School, completely out of the clinical environment, didn't see a patient for 2 years. And that's where I had the good fortune of meeting Michael Porter, who was one of my professors in my first year required course on competition and strategy. And this was before Professor Porter got interested in healthcare. And I really started thinking about competition and strategy and how healthcare was different in terms of how we compete and how we position ourselves strategically. I went on to do a few fellowships actually, and started my career at UCSF. And that's a few years later is when Porter and Teisberg wrote their book, Redefining Healthcare, where the term value in health was coined. And I immediately latched onto that and started teaching courses and doing research with them. And I think probably the most valuable thing I learned from my Harvard MBA and also from working with Michael Porter was just a different way of thinking about how we approach all the issues that we face in our health system. I think one of the things that we suffer from in healthcare is we say, well, none of those things apply because healthcare is different. And I learned just some basic frameworks from business school and from Michael Porter that I tried to bring into my day job that helped me think differently and opened up a number of opportunities for me and then really helped me just it opened up doors that I wouldn't have had otherwise and made my job a lot more fulfilling. I love the clinical part of my job. It's the favorite part of my job. And it also gave me an opportunity to be more than a clinician.
Yeah. So Kevin, you and I have known each other for, I guess, probably close to 25 years. And, you've named two of your mentors here, Jim Herndon and Professor Porter. But for the purpose of the listeners, you are one of my mentors. I probably wouldn't be on this call this morning were it not for your inspiration. If you recall, shortly after your MBA, you came down to Connecticut Joint Replacement Institute. We asked you to take a look at our fledgling program. And we all were dissatisfied with the current state, but just didn't know what to do about it, just didn't know how to react. And you advised us to read three books: Innovator's Prescription, Who Killed Healthcare, and Redefining Healthcare. Now, it took me a year to read each one because I'm a slow reader and absorber, but that was it. I mean, that was the inspiration for everything that flowed out of there. John was our hospital president, Kevin, so I give him a lot of credit for allowing us to evolve these principles. But you taught us to look at healthcare as a business. Healing is an art, medicine is a science, healthcare is a business. And all of the insights that flowed from there, we really attribute to you. So I wanted to officially thank you for inspiring me, and hopefully I've inspired a few others, and that's how it keeps on going. My other mentor is a colleague of both of ours, Bill Harris, who, when I was his fellow, every morning he would look over his YRMs and say, Steve, you got to leave it better than you found it. And of course, you and I just want to get on with rounds. We had too much to do, but those little things mean so much. And here you are now, 10 years in a leadership position at a new medical school, was new. Start to tell us a little about how you inculcate everything I just said to a first year medical student. How does this start?
Yeah, well, first of all, I just want to say thank you for those kind words. And I have learned as much from you as you've learned from me. And you've walked the walk and talked the talk, and you've really, operationalized a lot of the things that I've aspired to do and have been studying and interested in. And so you deserve a lot of credit for moving this field forward. I think the opportunity to come here to Austin, this sort of a greenfield opportunity, was probably what kind of catalyzed my ability to sort of implement some of these concepts because what you did is much harder than what I did because when you're at an existing institution to try to change culture and change a business model and change a mindset is really hard. I got to start from scratch. I was employee number one in my department. Now we have 57 surgeons and over 200 staff. And one of the unique things when you start from scratch, I hired every single one of those people. I didn't inherit anyone. So I got to select people who were going to fit with this culture and bought into this mindset that we're going to think about healthcare differently and we're going to think about our approach to payment and delivery differently. So I could screen out all the naysayers and all the skeptics. Now, that said, I think the diversity of thought is extremely important, and I want to surround myself with people that are going to challenge me every day. Is that the right decision? Is that how we're going to, grow and be successful? So I don't want all people that are going to agree with me on everything, but at least they're going to be bought into the fact that there's a better way of doing things. Everyone that's joined my team came from a very established place: UCSF, Mayo Clinic, Dartmouth, Harvard, Duke, Johns Hopkins, and they all came here because they thought there was a better way of doing things. And they left quote unquote successful places and successful jobs to start over. And so if you take that back to, our first year medical students, I think that the people entering into medicine today, each generation has a different sort of approach to life and the world. I would say this current generation is probably more altruistic. in my view, than we were when we went into medicine. I think a lot of people in my generation went into medicine because they thought it would lead to a relatively comfortable lifestyle, and they liked the status and the, being an important member of society. I truly believe that most of these kids entering medicine today, at least in our medical school, most of them have spent time in the Peace Corps or done medical missions, or they're people that really want to make a difference in society. They're also people that value work-life balance more than we did. So they are not afraid to tell you, I don't work on the weekends. It's not a badge of honor to say that you've worked, 80 hours a week anymore, which I think is healthy and a good thing. But I think that the concepts that we're talking about today resonate very strongly with this generation because they get to focus on the reasons they became a doctor to help people improve their health, and they can practice in a model where their incentives are aligned with those of their patients, which is very appealing to them from a lifestyle standpoint.
That's so true. And I'm fortunate to continue to teach some medical students, and I talk about, prevention of chronic disease. And I keep thinking of Steve and I both had the opportunity to attend Michael Porter's Value in Healthcare weekend course, certainly not an MBA, but we talked about an episode of care. It wasn't just about the arthroplasty surgery, right? It was osteoarthritis, and really talk about the entire episode and that journey and what can you do along the way to prevention. And so much of medical school, traditional medical school up until now, and I'm hoping Dell's different, has been about diagnosis treatment. You and I and Steve learned diagnose treatment, diagnose treatment, diagnose treatment, right? I say gout, you say colchicine. We don't talk about, well, what are the inflammatory things that the patient's going through, or their stress, or what's their diet like, and what's their physical activity like? We were never taught that. And how much of that is now being taught? It's great to give them that little intro you just said, but then once they actually get into school, how much is about prevention of chronic disease, which is really what's costing our society a tremendous amount. A lot of those $4.5 trillion are, as modifiable and preventable totally.
Yeah, it's a great point. I'll say that one of the things that I emphasize with anyone who works with me, if you spell the word healthcare, you have to spell it as two words, not one. And so in spell check, we'll try to correct it and merge them. And I say, nope, it's two words. There's health and care, and they're two different things. And care contributes to your health. It's certainly not the only thing that contributes to your health, and it's probably not even the most important thing that contributes to your health. And so if you look at all of us on this call and think about our health, the health care we've received over the course of our lives has made a contribution, but there are many, many, many other decisions that we've made and that were made for us through our genetic code and our socioeconomic status and other things that have contributed to our health. And one of the things that I emphasize, starting with the first year medical students through the residents, through our faculty, is that if you want to be a good clinician, you have to recognize your role in health care and the other factors that influence health, and you have to incorporate those into your decision making, how you interact with patients, how you set up your care delivery model. And if you don't factor those in, you're not going to be successful at improving health. And the other thing I always point out to people is our country, the United States, gets heavily criticized for spending more per capita on health care than any other developed country. We spend about 20% of our GDP on health care. But if you look at what we spend on social welfare in this country, it's almost exactly the same as any other OECD country. It's about 40% of our GDP is spent on social welfare. We just spend half of that on healthcare because we decided as a country that the path to health is healthcare. A lot of that has to do with very powerful lobbies in Washington, D.C., and powerful business interests. But the rest of the world recognizes that food security, housing security, the criminal justice system, education, all those things contribute to health, and they invest more in those and less in health care. And at the risk of being political, and I have my own opinions that I won't share about the current administration and the HHS, but the current Secretary of HHS, whose views on a lot of things I don't agree with, he has made it a focus that we need to focus as a country on health, and healthcare is a part of that. And so I'm bullish and optimistic about the next 4 years and I was just reading this morning about Dr. Oz and some of his philosophies, that we may have an opportunity to pivot a little bit and put the incentives back on health. So we'll see where that goes, but I'm going to remain optimistic until proven wrong.
Yeah, I read the same thing this morning, and I felt just regardless of what our political persuasions are, I couldn't agree more. I think we kind of started a little bit of that with the Affordable Care Act, talking about prevention, which I was excited back then, but I think this potentially could bring it up to a whole new level. Lisa?
Yeah, I'm just listening and enjoying the conversation and hearing about your experience. And I love the fact that you obtained your MBA and are focusing in the area of value or better health. I'm wondering what you think are the right actions, if we think about our administration, the right actions that would be necessary at this point to begin to pivot the system to more prevention and less chronic, catastrophic care.
So again, I would say I prefer the term health over prevention because again, it's a goal, right? So what are we preventing? Preventing is sort of the flip side or the negative side. I would say we're promoting health, and that's what we want. And in some cases, promoting health requires an intensive focus on care, and in other cases, it doesn't. So I don't like, for instance, when people say preventative versus, curative, or the one that really drives me nuts is the non-operative care versus operative care. It's a continuum. And if health is your goal, there are some cases where the best path to achieve health is through very intensive surgical, operative, high intensity services. And there's other cases where it's not. The main difference is the North Star you're chasing is health. And that's where when we talk about value, we talk about a framework for competition based on achieving the most health with the dollars that you spend. And John mentioned this during his introduction, but sometimes that gets misconstrued that the path to value is reducing the cost of healthcare, and that can contribute. But if you can provide the lowest cost, most efficient, high quality, safe healthcare, and unless it improves someone's health, you haven't created any value. And
Correct.
so it's really, for me, the North Star is how are we going to produce the most health and the best health outcomes for the people that we are privileged enough to interact with and take care of. And you have to have all of those tools available to you to do that. And it just so happens that health is inherently less expensive than disease. So if you focus on health, you will inherently spend less money over time on helping people get healthy because health is less expensive than disease.
Kevin, I want to first agree with you about the mindset of the kids, if you would, the medical students. So you've been there 10 years now and you've been able to track, you've had several classes come through. And at CJRI, we bring on 2 or 3 kids from the Network Medical School at Quinnipiac to do summer research with our registry. And I've been blown away with their worldview. I mean, these are kids that are 22, 23 years old. I didn't have a worldview like that till I was probably 50. Really, really a different generation. But let me ask you this, because in medical schools, even at UConn here in Quinnipiac, everybody goes in, they want to be a primary care doc till they talk to their friends who are orthopedic surgeons, dermatologists, gastroenterologists, and then everybody wants to become a proceduralist. In your 10 years there at Dell, have you seen a pivot? Because one of the bright spots today is direct primary care, subscription-based, advanced primary care. Are you seeing a little bit more of a pivot towards interest in becoming a primary care physician at Dell?
I wish I could say that. We established, and some of our funding came from, and still does, from, public entities that have an interest in expanding primary care. I think nationally, we haven't solved that problem, and it has to do with incentives. So yes, we put an emphasis on it, and yes, I would say probably, I haven't looked at the numbers, but I would suspect that we only have 50 students a year that graduate, and I would suspect the percentage of those that go into primary care, which is not just family medicine. It includes OBGYN and pediatrics and other things, or primary care specialties, is probably a little higher than the national average, but still the incentives are on the surgical subspecialties, and they will remain that way as long as our incentive system works the way it is. I mean, we were talking earlier about, health and care. The highest paid professionals in all of medicine are us, the people that fix things that are broken, and the people that focus on health, the pediatricians and the primary care physicians, are the lowest paid. So as long as those incentives remain that way, where the incentives are on care, I don't know that we'll make much of a dent. We can rely on their altruism to a certain extent, and I do think that that's probably led some people to make a decision that they realize they can maybe have a bigger impact as a primary care physician. Certainly, there's plenty of jobs, but the financial incentives in many cases dwarf that.
Yeah.
We could have a whole conversation about the rock and compensation and all that, but that'll take us down a path. So let me get back to what transformed a lot of us is Michael Porter and Elizabeth Teisberg's book. Where are we, Kevin, and where are you with the Michael Porter definition of value, right? The outcomes that matter to people over the cost to deliver that care. What you guys do, what you orthopedic surgeons do, you measure outcomes typically as they didn't get an infection, they didn't die, they didn't get a DVT, they didn't get a transfusion, all laudable goals. And I'm sure you guys, like Steve taught me at Cedar Eye, you can reduce a lot of the variability. My God, to get 10 orthopedic surgeons to agree to what's the best prophylaxis for DVT took a year. But are those really the outcomes that matter to patients? So where are we in the global sense of trying to create what Michael Porter talked about, was consumerism, right? Value, cost, the consumer should be able to shop just like they shop for television. Where are we in that?
Yeah, I think that we as clinicians play a big role in that, and we are in large part responsible for the dearth of information that's available to consumers because we hold our cards close to our chest. And so, I always say if you want to know, where to have your hip or knee replaced in Hartford or who should deliver your baby, you have to talk to somebody on the inside, right? Because they know, but the average person in Hartford can't get that information.
Exactly.
And so it's very frustrating. It's the opposite of free market competition, right? Because there is asymmetry of information there. And I think if you look at what we measure today, I always, when I talk to groups about, I'm actually working with Joint Commission and NQF right now on new standards for their Center of Excellence programs. We measure things like structural measures, nursing to bed ratios, adoption of electronic health record, process measures, use of antibiotics and VT, experience measures, which that's the one that I always point out. And Elizabeth, I learned this from Elizabeth. I think that's the most misinformed because in reality, no one wants to experience healthcare. They want to be healthy. And if any of us could get healthy without ever touching the healthcare system, that's what we would choose every single time. So it's not about, oh, well, did you have a great experience getting chemotherapy for a year? It's, are you healthier than you were when we started this interaction? And then the final one, again, that you pointed out is quote unquote quality and safety. Because again, yes, if you do high quality and safe work, that can contribute to value. But if you're doing a high quality, safe spine surgery on someone who's not going to improve their health and not reduce their dependence on opioids, I'm not sure that it matters whether it was high quality or safe. I think that's wasted dollars and wasted, part of that person's life. And so I think that the part about measuring health has to come ahead of all of those things. And I think that in our world, that means patient-reported outcomes. Does the patient feel that they're healthier? If they don't, it doesn't really matter what we think. We can't tell them, oh, you're doing great. Look at your x-ray. Look at your, how I feel. And so it doesn't really matter.
Right.
And the other thing I'll point out is when we talk about practicing in the value framework, that we talked earlier about the moral injury that occurs between, the burden and the purpose of our work. When you are being measured on all the bad things you do to people, and that's when I get my leapfrog report and it tells me how many people I killed and maimed and infected, it's very demoralizing.
Yeah.
And when I get a report that tells me how much I improved someone's quality of life and reduced their pain and enhanced their function, that's really energizing for me. And it's very much aligned with my interests and why I'm doing what I'm doing. So I think not only is it a better way to measure value, but it's also more consistent and more aligned with the interests of the clinical team and less demoralizing like many of the things that we measure today.
Well said.
Yeah, I love your thoughts there. Nobody wants to experience healthcare. That's a great way to look at it, right? We all want to be healthy. How do you communicate to those that you are molding for the future how do you communicate how to manage in the environment they're in today with a perspective like what you have, wanting things to be different, measure the right outcomes that are rewarding to you as an individual, rewarding to the patient, but working in an environment today where everything else that's done is counter to actually that perspective, or that level of measurement, let's say, especially in a value-based arrangement or value-based world where our doctors complain all the time about the number of measures that we have, over 500 measures. They don't agree with half of them. They don't agree with the outcomes, and they feel there are better ways to approach this. So I'm wondering how you manage that conversation and build resiliency in the new doctors.
Yeah, I would take it a step further and say in all doctors, right? So every time we hire someone, we have a program we put them through where we indoctrinate them on the importance of measuring outcomes from the patient's perspective and how we utilize patient-reported outcome measures in our practice. So I call the patient-reported outcome measures the engine that drives everything we do in our practice. It drives everything from triage, who the patient sees when, to decision-making, medical. We have a shared decision-making tool that we use that's driven by the patient's self-reported pain, functional status, quality of life, mental health. We use it for performance improvement. We use it for segmentation. So that's probably the most important thing that we do and I do, is help people realize the value and the benefit of understanding health from the patient's perspective. And when I talk to medical students, I say, just the first thing that you should do if you're in front of the patient in the emergency room in a clinic and making rounds is, why are they here, and what do they hope to accomplish? Why are you here today, and how can I help you? And understand what they desire. And in many cases, we've actually trained patients to say, "Oh, I'm here because of my X-ray." Well, I don't know that your X-ray is going to make you feel better, right? Yeah, you told you have bone on bone, whatever, but why are you here? What do you want? Well, I was told I have bone on bone and I need a surgery. Well, okay, but what do you want to accomplish with that? What's your goal? What are you trying to achieve in your life? And I always bring the conversation back to that. And I ask everyone from our first year medical students to our residents to our, advanced practice providers to our physicians and surgeons to really make that their primary focus.
Yeah. Kevin, I want to just pivot for a moment. Many of the principles I learned from those three, the trilogy, I call it, the books you asked us to read, was the concept of an integrated practice unit. And I think back, it was 18 years ago. And as John and I took the value measurement course, and we did these case studies of the Martini Clinic and the Headache Clinic and so forth. And that's always stayed with me. And as John knows, we tried probably 13, 14 years ago to develop integrated practice unit in the Hartford area. And the financial incentives just weren't there. We tried really, really hard to do MSK and primary care. And, sometimes you go into these things, Kevin, not knowing the challenges, and you're better off not knowing them. Just go and try to, but they fail. But through my startup, which is an MSK company, I sense there's some movement towards an integrated practice unit. Now, very few people know that word other than the folks that read the book or know Porter and Kaplan. But, they refer to it as an ecosystem around obesity, where with MSK, behavioral health, cardiometabolic, kidney disease, it's starting to resonate, right? That's on the provider side. On the plan sponsor side, they're getting tired of point solutions. We hear about, I got a point solution for 80 different things, but no one talks to each other, right? I've got an obesity point solution, blah, 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 blah. So we've got this supply and demand that both want the same thing. The challenges we're having is coming up with a model that brings everybody together, right? Because what is the reimbursement model for these four companies? Any insights as to how we can actually accomplish an integrated practice? Yeah, I really love your thoughts on that.
So let me just start by saying, I think, yes, the incentives matter, and certain incentives, and we might get into talking about longitudinal payment models and condition-based payment models, which can incentivize how you organize care. But I don't think there's anything inherently wrong or bad or disadvantageous around organizing care around conditions, even in a pure fee-for-service business model. And let me explain that. So if you think about The first thing that Porter and Teisberg asked us to do is don't think about care organized around physician specialty. Think about it organized around conditions. So the patients that we treat come with a variety of different symptoms. And depending on the condition, there may be some very, very common, let's call them comorbidities. So in people with chronic musculoskeletal problems, a high percentage of them have some behavioral or mental health issues. They have either difficulty with coping with pain. You can call pain self-efficacy. You can call it anxiety, depression, whatever you want. A lot of those words are stigmatized. And a high percentage of them have weight issues, and they're either overweight or obese. And so if you organize care around physician specialty, in this case, orthopedic surgeons, you're going to have someone who is not trained in either of those disciplines, not even how to treat it, just how to recognize it and incorporate it into your decision making. So not only are you going to do a poor job, but it's going to lead to that moral injury problem where if I'm sitting in front of a patient with a BMI of 50 who's depressed, who tells me their knee hurts, I'm going to be really frustrated because I have nothing to offer this patient. And they're going to be extremely frustrated because they're going to say, I did nothing to help them. If I have a team of professionals who can help them understand how their weight is contributing to that pain and how their mindset is contributing to that pain and how we can maybe modify some things in their lifestyle that can actually help them, now we've given someone that can help them, and it's freed up me and my team to focus on the people that are more going to benefit from my area of expertise. So it's incredibly beneficial, not only from the patient standpoint, but from reducing moral injury and turnover and leading to higher retention rates. So I think when you think about an integrated practice unit, you call it whatever term we want, think about the conditions you treat and all of the different competencies that you need to treat that. And in many cases, that doesn't require physicians. And so it doesn't have to be expensive. And you can set up a model in a way where having a very expensive orthopedic surgeon counseling people on weight loss and activity modification is not only not very effective, but it's not very, you're losing money doing that. You don't want your orthopedic surgeon in a fee-for-service environment sitting in front of someone trying to help them lose weight.
Violates the TDABC principles there.
Exactly.
For sure.
So I would disagree with the concept that the fee-for-service model doesn't lend itself to high-value care. Even if you just took the reduction in turnover, our practice has been open since 2017. I think we're now up to 40 some people in our practice. And, there is less than 5 people that have left us since we opened our doors. I've hired 57 faculty since I've been here. We have 57 faculty here. None of them have left. And so even if I just measured, the cost of turnover and, retention alone, that would pay for, a $60,000 a year social worker to be integrated on our team. So when I hear people say that's a really expensive model, we can't afford it, I think that's very short-sighted. And I don't think they're looking at their overall ability to provide high-value care, how it influences the job satisfaction and the retention of the people on their team, and how it aligns their incentives with their patients. And I think you can do that very effectively in a fee-for-service model. I'd say 70% of our patients in our practice are in a fee-for-service plan. 30% are in a longitudinal payment model. We do well on both. Yes, we do better if they're in a longitudinal payment model where we're incentivized to get the most health for the lowest cost, but we don't do bad in the fee-for-service model either.
Yeah, I'm interested in what you think about the impending supply and demand issues with physicians in almost every specialty, right? And the potential impact of that on managing health outcomes to, better position like you're talking about. And we certainly need physicians in order to manage the care and get our citizens more healthy. But when you have less and less individuals enrolling in medical schools and less enrolling in primary care, and you have an aging population that, by 2030, what another 30% are going to age into Medicare or something like that, where that's the typical time period where there's more chronic conditions. So the need is higher because the activity and the volume of work in elders is greater than for the young, healthy population. So what do you see the potential solutions being for the supply and demand issue? Because absent, having some solutions, we're probably going to still experience cost escalation and poor quality.
Yeah, so you're talking about sort of the demographic tsunami that's
Yeah.
happening in this country. We will not be able to manage it the way that we have. And I would push back on the concept that what we need to do is train more physicians. Again,
Mhm.
as we talked about earlier, if we're going to focus on health, that doesn't necessarily mean more, six, seven-figure physicians. And I think that we need to train a workforce of people that are able to, and when you make the focus health, that requires different skill sets. And this require, I mean, Steve referenced the Innovators Prescription and Clayton Christensen's work earlier, and he talks about downstreaming care so that you want care to be provided by the person who has the skill set needed at the lowest cost. So in our practice, for instance, we do a lot of cognitive behavioral therapy. We could have a psychiatrist do that. We have a licensed social worker do that. They do it just as well, and they're a fraction of the cost. And they like doing it. Sometimes, psychiatrists would be rather doing other things, right? So I think that we have to find that, but in medicine historically, in organized medicine, and I'll acknowledge as I was president of the American Academy of Orthopedic Surgeons, we have fought these scope of practice turf battles and said we don't want people that don't have our training being involved in our business. We don't want midwives delivering babies because they don't know what to do if somebody, has a complication, or we don't want, PAs or nurse practitioners doing primary musculoskeletal care. And that's put us at the opposite. So now everyone's operating at the bottom of their license, which is not only more expensive, it's less fulfilling. So we have to let go of those turf battles and say, hey, if a podiatrist can, take care of somebody's toe with less training and less years of experience than I have, maybe fix an ankle fracture, I don't know. Why not let them do that? And I'll train orthopedic surgeons to do really complex stuff that the podiatrist can't do and figure out how to integrate them on a team. But we have to let go of these scope of practice battles and these turf wars that we spend so much time on. I always point out when I talk to orthopedic surgeons and say, well, these damn podiatrists and chiropractors, they're infringing on our world. They say, well, guess what? If you talk to the radiologists, they'll say the same thing about you. How dare you read an MRI? You don't have 5 years of training reading MRIs.
Right.
You don't know what you're talking. You might miss a cancer and somebody might die. You're dangerous. You shouldn't be doing that, right? So I think that to answer your question, we need a workforce, and we need to think about how can we get everyone practicing at the top of their license, which not only is more cost efficient, but it's better for retention and job satisfaction because now everybody's doing the things that they love doing. So in our practice, we have the medical assistants doing things that in other practice nurses would be doing. We have nurses doing things that in other practice nurse practitioner would be doing. The nurse practitioners that are doing things that in most practices physicians would be doing. And, up the line, because we want everybody to feel like they are doing what they were trained to do and they love doing and not being shoved down into a box somewhere.
You're I've got scars on my back from the fights when I was a hospital president with not Steve, but with orthopedic surgeons and podiatrists talking about privileging, and I don't even want to go there because God bless you for everything you've just said, Kevin. So, truth be told, Kevin, we don't have to look far. Well, maybe far is not the right term because geographically it is. But the Nuka health system in Alaska that you may or may not be familiar with has done exactly what you're talking about. And I think we all should take a field trip there because what they have done, and it's mostly, paid fee for service type of model still. They actually own a hospital, the Nuka Health System, South Central Foundation. They cover, as you can imagine, Alaska, right? Alaska's a big state. Two Texases for you Texans fit in Alaska. They cover the south area, southern area with Anchorage, remote villages. They've reduced the cost of care. They've reduced hospitalizations. They've reduced ED admissions. They have 95% customer, they call them customer satisfaction or clients, and 95% provider satisfaction. But what they've done is they've created a model of care that has a and they don't call them patients, but that the customer client is at the center. And they really focus on what you've said earlier in this talk, which is about the health and outcome. What do you want? And if the person says, "Well, I want to be able to play with my grandchildren someday," that's the goal you aspire for. And they bring the family into the whole thing. And it's usually a family practitioner with a nurse, with an MA, and some nurse navigator type person, a customer service representative, probably not a highly trained person who helps navigate the healthcare system. And that's it. That's the core group. And then surrounding that, they have then a psychiatrist, not a psychiatrist, but a licensed clinical social worker, a nutritionist, a pharmacist that works with a patient, especially a patient on, multiple medications. They might have side effects and all that. And then there's an outer ring that starts to bring in the OB/GYN or midwives or some of the specialists or colorectal person for screening and orthopedics and the higher trained specialists are in the outer rim. Those outer rim folks care for probably 3 or 4 of these pods, and they've done it. They've lowered the cost, they've improved the outcomes, they're focusing on health, and it's all about the health and wellness to your point. And so it's being done already in America, and people from the irony here is people from all over the world go to see the Nuka Health System in Alaska. And I'm like, why aren't we all going up there? So it's possible. You can do it. And with exactly all the things you've just said, which are, you don't need to reinvent the wheel here. You guys, we are indeed, what you've done is learn from your TDABC training and Harvard Business School and have the lowest cost person provide it. Look at the entire episode of care, look at the, value stream mapping. You've done it all because you know how to do all that. But I'm telling you, they're doing it already and it's worth a trip.
Well, that's great to hear. I do not know that health system. I'm going to go do some research on it now that you told me about it. And that's exciting. I'd love to learn more about what they're doing. And I will say, when I talk to different groups about value-based healthcare, and I hear them say, "Well, we're going to pivot when the payers make us pivot, or when the government changes something." I tell them, I give them the quote from Gandhi: "Be the change in the world, that you want to see." No one is more responsible for how we deliver and pay for healthcare than physicians. And we're the people that the rest of the world trusts. Society trusts us. They don't trust the government or health plans or bureaucrats or anyone else to fix these problems. They want us to do it. But that requires us to get off our you-know-whats and stop fighting to preserve the status quo and be a disruptive change. And I'm glad to hear there are health systems like Nuka that are doing that, instead of sitting around saying, "Well, I'm waiting for some stimulus from some other entity." How about we just be the catalyst and we drive the change rather than being the laggards?
Yeah, there'll still be plenty of business left for us. I don't think we'll have to worry about that, to your earlier point. Steve, give you the privilege of the final question here.
Yeah, Kevin, we have a tradition on the podcast of asking our guests who come from a very diverse background and different skill sets what their view of healthcare, what it's going to look like in the next 3 to 5 years, maybe even less. But given your very unique position, your vantage point as a clinician, an educator, a scholar, a national leader, I'm going to just change that question just a bit. I want you to imagine, because I'm also bullish too. One of our colleagues, Dr. McCary, is the head of the FDA, and I listened to a podcast on Honestly with Dr. Jay Bhattacharya, the head of the NIH. You have Dr. Oz and RFK. So there is some bright spots there. But if you had them in the room, what single piece of advice would you give them today to have the greatest impact on our healthcare system that would lead to the outcome we're looking for?
Wow. I would have rather taken the traditional question, but I'll answer that one first, and then I want to get to the traditional
All right,
question.
Kev.
I think that what we've been talking about all along here, which I do believe is one of their founding principles, is my simple advice would be, let's make the focus on health and the incentives and everything that we are building, whether it be NIH funding to setting rates for services, to looking at alternative payment models, to incentives for organizing care differently. Like if we could get the country focused on the whole end game here in healthcare is health, that would be a step forward. And as far as how I think that's going to play out in the next 3 to 5 years, I know we've been saying there's sort of been a crisis building for a while. I don't know about you guys, but I haven't looked at the market yet today. I'm afraid to, but what's going on in the world right now with tariffs, if you look at what's about to happen with cuts in Medicaid funding, cuts to NIH funding, we can't, the organizations that have slipped by with the status quo because they're afraid of change, it's not going there's going to be an implosion in these next 5 years. And this administration is going to force that, and that could be a good thing. If you look at the number of health systems now, it sounds like you guys read Becker's every morning like I do. The number of health systems that are profitable is dropping like a stone. And when I say profitable, I mean like 3 to 4% margins. That's a good margin today. Most of them are underwater. Rural hospitals are closing down. Everyone's trying to get rid of government funding sources. The cuts in Medicaid are going to be devastating especially for blue states. The status quo just isn't going to survive, and I think that's a good thing. I think that this crisis that's being created and it is being manufactured by the current administration will potentially it will lead to significant pain and disruption, probably loss of life, loss of, ability to innovate in the short term. But maybe the silver lining from that will be we finally realize that we can't continue on the current path. We can look at the GDP and other things and say, boy, this is unsustainable. But as long as the stakeholders in healthcare, whether it be Eli Lilly or, Stanford Health or United Healthcare are making money, nobody's going to say, oh, geez, that's horrible that we have this unsustainable growth in healthcare costs. But as soon as those organizations are no longer able to make money in the current business model, things are going to change. And I think that's where we're headed.
Perfect. Thank you. John?
Yeah, no, Kevin, thank you so much for joining us today. I think you should make sure you stay where you are, because if you become a hospital president, you'll find all of a sudden like, oh, wait a minute, the things I just talked about are going to drive me, underwater. So and that's really one of the fundamental challenges, honestly, that I faced in my career. So wait a minute, am I really doing healthcare, to your point? Because you're not. When you're a hospital president, you're doing sick care, and you talk about you want your population to be healthy, but the reality it is not really from a fiduciary point of view. It's like, no, I need to grow the business, right? But we certainly appreciate having you on. You're a shining light in a challenging space, and disruption is certainly coming one way or the other. We couldn't agree more. So thank you for joining us today, and have a great day.
Well, it's been a real privilege for me. I will say this is definitely, I can tell right now it's going to be the highlight of my day, because I'm going to leave here and go back to fighting with health system administrators and health plans and those kind of people. And so getting to talk to some like-minded people who've got some really good ideas and energy and passion is what drives me. And so I appreciate the privilege and the opportunity to have a conversation with you guys. And I certainly learned from all of you, and I'm going to go look up Nuka Health System after this call.
Thanks, Kev.
Thank you.
Thank you. To learn more about MTVA and how to join our community, visit our website at www.movingtovalue.org. If you enjoyed this conversation, please follow us and leave a review on Spotify or Apple Podcasts. Thanks again for listening and for being part of this important movement.